He is Associate Chief Physician in the Emergency Department of Beijing Qinghua Chang'eng Hospital, and also served as a youth committee member of the Emergency Medicine branch of the Beijing Medical Association. Her main research direction is emergency infectious diseases. Now we invited Song Linlin. Please, Linlin.
Okay, thank you, Yiqi. Okay, can you see my slides?
Yes.
Oh, okay. Good afternoon, everyone. I'm so glad to have the opportunity to give my presentation today. My topic is early diagnosis of bloodstream infections. Bloodstream infection is a serious condition. It has high morbidity and mortality, and there is a high risk for BSI patients to develop sepsis or septic shock. In my opinion, the most challenging issue...
Your slides are not moving.
I know.
Okay.
Thank you. In my opinion, the most challenging issue of BSIs at present is how to detect BSIs at an early age. And my presentation will be centered around the following aspects. Firstly, I will introduce a real case in our ER, and then the challenges we are facing, and when to suspect BSI, and the last, how to identify BSI. This is a real case in 2023. Mr. Dai, 80-year-old man, who was admitted in our ER with fever, chills for half a day. He had diabetes before, and on his arrival, he had high fever, tachycardia, tachypnea, and low blood pressure. And the laboratory tests showed the inflammatory markers are really high. And the abdominal CT scan revealed left kidney stones, ureteral dilation, and kidney and perirenal abscess. And the blood culture, we cannot wait the blood culture to tell us what is the pathogen, right? So for this patient, the primary infection site is the urinary system, and there is a high probability that he has developed a BSI and septic shock. To save this patient, in addition to timely drainage, it is important and urgent to identify the pathogen and its antimicrobial resistance situation. Apart from blood culture, are there any other options to detect the pathogen? There were several challenges we are facing now. BSIs are prone to cause sepsis and MODS, and the prognosis of BSIs is closely related to the timeliness of diagnosis and accuracy of diagnosis. We all know that antimicrobials should be administered within 1 hour in patients who have septic shock. However, approximately nearly 46% of empirical antibiotic treatment was inappropriate in clinical practice, resulting in poor clinical outcome and increased antibiotic resistance. Therefore, the rapid identification of pathogens and the early use of targeted antimicrobial therapy are urgently needed. At present, the gold standard for the diagnosis of BSIs is still blood culture. It can provide the organism for identification and antimicrobial susceptibility testing, but it cannot meet our clinical needs due to the low positive rate, long turnaround time, and large blood collection volume and easy contamination. Meanwhile, a large proportion of BSI's patients were not subjected to blood culture tests on their arrival because the doctors failed to recognize that the patient might have a BSI. So, when to suspect BSI, we need to enhance our vigilance against BSIs. BSI's patients may have several clinical signs and symptoms such as high fever, chills, or rigors, tachycardia, tachypnea, altered mental status, and so on. And there are also some risk factors of BSIs, such as advanced age, more than 65 years, and immunosuppression, such as cancer, renal failure, hepatic failure, AIDS, diabetes, or obesity. And if the patient was admitted into intensive care unit, or they may receive the invasive medical procedures such as mechanical ventilation and intravascular catheter placement. And laboratory tests may find some inflammatory markers such as CRP, PCT, lactate, and NLCR, and etc. And we also can use some predictive scores such as QSOFA, SIRS, NEWS, Shapiro score to help us to predict the BSI. This systemic review and meta-analysis revealed that shaking chills are a highly specific but less sensitive predictor of BSI. Blood culture and early initiation of antibiotics should be considered for patients with an episode of shaking chills. However, the absence of shaking chills must not lead to exclusion of BSI and early antibiotic treatment. This is Shapiro's score. It has several covariates, include age, temperature, suspect endocarditis, indwelling vascular catheter, and chills, vomiting, hypotension, white blood cell count, bands, platelets, and creatine. But in many EDs, pandemia cannot be routinely obtained in a timely manner. So a modified Shapiro scores has been proposed, which replaces pandemia with neutrophil white cell differential more than 80%. This research from Japan highlights that sepsis-3 definitions and QSOFA predict BSI with high specificity. Shapiro scores predicts BSI with high sensitivity, and Shapiro score was most useful when screening bacteremia. This research compared QSOFA, SIRS, and Shapiro score, and the result is that the modified Shapiro score had the highest sensitivity with modest specificity, and QSOFA had the highest specificity with poor sensitivity, and SIRS had the reasonable sensitivity with poor specificity. And the last part is how to identify BSI. This is a newly published Nature review on bloodstream infections, mechanisms of pathogenesis, and opportunities for intervention. There are several diagnostic approaches for bloodstream infections, and some of them rely on blood culture. So they have the same disadvantage of long turnaround time. And there are some other approaches do not rely on blood culture, such as multi-TOF mass spectrometry. It is not very popular in our in hospital because the instrument is expensive and the ambiguous identification of some closely related organisms, and it requires a culture isolate or purified suspension. And gene or genome sequencing, we are very familiar with them now, such as the NGS, next generation sequencing. It is very popular now. It can be it's some kind of gold standard for identification of BSI, but the time is a little long. They need overnight 2 days to get the results, and the result requires expertise for interpretation. So we focus on the direct PCR from blood. It is rapid and can be highly sensitive and specific. Then I will introduce the dPCR. dPCR, which is called the third generation PCR technology. In the first generation, we all know that it's PCR gel electrophoresis. And the second generation PCR we call qPCR. It's kind of it can get relative quantification result. And the third generation digital PCR, it can reach absolute quantification. And dPCR, an emerging tool for rapid and sensitive pathogen identification bedside test, has developed to address the current challenges of BSI diagnosis and precise treatment. It is expected to become a key upstream technology for a wide range of applications now. The principle is PCR plus microfluid chips. Compared with qPCR, digital PCR separates the reaction system into independent micro units, enabling target amplification at the single molecule level. This design can reduce intermolecular competitive inhibition, significantly reduce background interference, and improve the decision signal-to-noise ratio, ultimately achieving high precision absolute quantification. And it has higher sensitivity, and just like finding a needle in a haystack, and it can reach the superior reproducibility. Now, dPCR is used in several clinical scenarios, such as tumor fluid biopsy, minimal residual disease, and birth defect screening, and severe infection, include BSIs. We did a little, we did an observation. We collected 106 patients in our emergency department who presented with high fever, accompanied by chills and elevated PCT levels. The positive detection rate of dPCR was 62%, and the positive detection rate of blood culture was 47%. And this research is from Shanghai Huashan Hospital for suspected bloodstream infections. From 110 patients, they collect 142 blood samples and divided them into two groups. 53 samples collected before empirical treatment and 89 samples collected after empirical treatment. We can see that the dPCR positive numbers are more than culture positive. And dPCR reported an overall 85.7% sensitivity in patients. And compared to blood culture, the overall detection rate of DPCR was significantly higher, 30.3% versus 11.3%. And of the DPCR positive culture negative cases, 74.2% was consistent with the final clinical diagnosis. And the detection rate of DPCR was significantly higher in patients with white blood cell counts, CRP, or PCT. Pathogen loads detected by DPCR are correlated with white blood cell count, CRP, and especially PCT levels. And correlative analysis showed the correlation between the clinical inflammatory indicators and the pathogen copy value detected by DPCR. CRP had a positive correlation with the pathogen loads detected by DPCR, and PCT had a significant positive correlation with the DPCR results. However, the white blood cell count was shown to be less correlative with the pathogen loads detected by DPCR. And according to the results of DPCR, medication regimens were adjusted and pathogens were covered in more cases, from 42% to 84%. And this is another research. According to the samples were divided into 4 groups according with whether the blood culture is negative or DPCR is negative or not. According to clinical manifestations, DPCR positive and blood culture negative group were further divided into 3 categories, including probable BSIs, possible BSIs, and putative force. DPCR showed a sensitivity of 90%, a specificity of 55.5%. After considering the probable and possible BSIs, the diagnostic value of DPCR improved with a sensitivity of 92% and a specificity of 78.5%. This data suggests that DPCR has the potential to rapidly identify and exclude target pathogens, since blood culture testing might generate false negative results due to factors such as antibiotic use. And comparison of the laboratory indicators between different groups showed that the levels of interleukin-6, CRP, and the neutrophil percentage in the DPCR positive blood culture negative group was similar with that from the DPCR positive and blood culture positive group. However, the above 3 indicators were significantly higher than those in DPCR negative group, suggesting that the plasma inflammatory profiles were comparable between the DPCR positive blood culture negative group and the DPCR positive blood culture positive group. Analysis of the correlation between bacterial loads determined by DPCR and the inflammatory indicators showed interleukin-6 and CRP were significantly positively correlated with the bacterial loads detected by DPCR, while PCT, white blood cell count, and the percentage of neutrophils and the lymphocytes showed weaker association with blood bacterial loads. And this is another research in ER. It's a prospective single-centered observational study. And the DPCR results were positive in 48% of episodes with identification of 132 pathogens. In contrast, blood culture only detected 18 positives. And dPCR shows an overall sensitivity of 88.9% and specificity of 55.6%. And the optimal diagnostic power for quantifying BSI through dPCR is achieved with a copy of 155.5, which strikes a balance between sensitivity in detecting positive BSI patients and specificity in identifying case controls. The AUC is 0.855. And this research shows the sensitivity of dPCR was markedly higher compared to culture method. And in suspected BSI cases, the combination of dPCR and inflammatory markers could predict sepsis risk. And dPCR monitoring combined with PCT holded predictive value for SOFA progression. And dPCR combined with interleukin provide a more accurate and expedited insight into clinical outcomes prediction for BSI confirmed patient. And this is a real case published. The dPCR tests were performed 7 times in total during the patient's hospitalization. Considering that the patient's body temperature and inflammatory indicators were normal for a week, the doctors stopped anti-infection treatment on April the 6th. But on April the 8th, the patient had a sudden septic shock. The dPCR showed E. coli copies was 7,000. And similarly, the antibiotics was discontinued on April the 19th as the patient's condition kept stable for a week. And the patient relapsed with septic shock again 3 days later. And the E. coli copies was 2,100. Then the patient was treated with continuous imipenem until he recovered and was discharged. And back to our patient, Mr. Dai. He was the first patient who received the dPCR test. And after only 3 hours, the dPCR reports Enterobacter cloacae. And after 6 days, blood culture reported. And after 4 days, urine and drainage fluid culture reported the same bacteria. So we can see that dPCR in BSIs can early detect the pathogen, can guide our treatment, can dynamic monitoring, and has some prognostic value. That's all. Thank you.
Thanks, Dr. Song.
Thank you.
Hi.
Thank you. My English is not very fluent.
No, I think that was a really interesting lecture. I've got questions which I will bring up during the Q&A. Right. Our next speaker is Dr. Liu Zhenyong from Singapore, SingHealth. Okay. Zhenyong is a consultant with SGH Department of Emergency Medicine. His current clinical and research interest is in sepsis, and this coming November, he will actually be doing his fellowship over in Vancouver to look at sepsis systems of care, as well as advances in sepsis management. Usually when he's not working, he enjoys video games, exercise, reading, and all. So without further ado, can I present Dr. Liu to start his lecture? Thank you, Dr. Liu.
Okay, hi everyone. I'm Zheng Hong here. Thank you for the introduction, Dr. Lee, and very interesting talks by the previous speakers. I think they have given a very nice, Prof. Chen has given a very nice overview of the latest in sepsis. And I find the talk about the biomarkers very exciting because I think that will be the future in terms of stewardship and all that. First of all, y'all can see my screen, I think. If there isn't, please let me know. Today, for my part, I'm going to take a little step back to actually talk about phenotyping and subclasses, okay? No disclosures relevant to this topic at least. Okay, so first of all, we said we take a step back, right? So what exactly is sepsis? That in itself can be an hour lecture, but being something that has been described since ancient times, even attempts in recent times to give a proper criteria has not been, in my opinion, very successful, right? We went from sepsis 2, where we have very nice SIRS criteria and all that, and now sepsis 3, we have essentially some sentences and some guidance on how to include patients as active patients. Okay, so let's take the researchers away, right? We know that sepsis exists because we see patients, and we know that they exist. Okay, so I wonder if you guys know. Wait, there's a chat. I wonder if you guys know who said this quote. Okay, this is a tidbit. Really, this is an American Supreme Court justice, okay, describing at a point in time, the question was, is some of this artistic material considered art or pornography? Okay, he said, when I see it, I know it. Okay, and it seems that for sepsis, some people believe, right? I know it when I see it, right? Because these folks from Minneapolis published papers saying that, Gastot is the best way, or rather, is as accurate as all the screening tools. Essentially saying that, I know what it is when I see it. Of course, these papers has its issues, but that's another discussion. Okay, so now we have ended on this description that sounds more not so objective, in a sense that what is life-threatening? What is the definition of life-threatening? When do you consider it an end organ dysfunction? When do you consider it to be caused by the dysregulated host response, so on and so forth? Kind of leave it up to us to decide. Some places, some agencies like CDC has tried to create some criteria for screening and surveillance, but still lots of arguments. So very interesting space. For us, clinicians, we have a lot to publish because nobody really knows exactly what is the inclusion criteria. Now we move on to the next thing. Over the past maybe 10, 20 years, everyone, it's one of the big things, especially in the West, right? But everything, I would say almost everything has failed, right? So, and the interesting thing is that they always succeed in the smaller trials and to fail later. So this includes what I learned in residency of oligo-directed therapy. During my residency, there was talk of MAREC protocol, which is vitamin C. Okay. New immunomodulators like listed here have all failed subsequently. Okay. And why is that so? What we do know is that sepsis overlaps with so many different things, right? So this diagram created in the sepsis 2 era shows that sepsis is actually, when there's infection and inflammation overlapping, and within sepsis there's bacteria, fungi, parasites, so on and so forth. But even this diagram, in my opinion, is misleading. Okay, it's misleading because sepsis is being indicated as one group in the middle. Okay, and if you Google colon cancer, right? Colon cancer is not a single disease, right? You don't do trials on colon cancer anymore, right? It's simply a description of a category of cancers that start in the colon, right? And you can have adenocarcinoma, blah, 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 blah. But we still treat sepsis pretty much as one group for practical reasons. And we do trials on them as one group for practical reasons. And that's probably why the trials are negative, right? Because when you start off with a smaller specified group, in the earlier slide, you can see, right? Some of these trials went for severe sepsis or biomarker-guided treatment. But when they go to apply to all patients, when they are essentially a different disease, then they fail. So now we talk about that as a broad concept. And really for sepsis, if we want to still talk about sepsis as a single disease, okay, we're talking about heterogeneity on all fronts. Okay, let's not talk about treatment heterogeneity because that's something that we do. But clinically, patients present differently and they have different end organ dysfunction if we go by sepsis 3 definitions of sepsis. They have different infections, okay, whether it's loculated, whether it's an abscess, whether it's pneumonia. Their own demographics affect how they generate the immune response. Okay, and of course, the microorganism, right? You know, how much microorganism, as I mentioned, whether they are compartmentalized, resistant, so on. And so it's, you know, we shouldn't be looking at sepsis as one disease, but really multiple diseases, right? So now I'm wondering, why did I choose to do research in this area? Because it seems to be getting quite complicated and difficult for me, actually. And the last thing that I drew a very lousy diagram is that all of these has to be, you know, it's not a simple cross-sectional snapshot that we just run a logistic regression and say that, look, okay, we have adjusted for all these variables. All of this has to be put over time, right? So this is something that Prof. Chen alluded to and spoke about in his talk just now, right? What is the time zero of sepsis, right? Unlike a vascular event like stroke or AMI, which has a very clear time of onset, sepsis is very hard for the patient to tell you when he or she started feeling unwell. Okay, so we have to take all of these variables, adjust it for time, before we can even start talking about which group we are treating and how. Okay, so how did we do that in the past? We can't. Now, you know, thanks to the people who are working hard on AI like Prof. Chen, thanks to all the databases and our electronic health records, we have a chance, right? We have a chance with all this data. Hopefully, we sort out the ways institutions share data, but with the kind of computing power we have and the new techniques we have, we might be able to understand this massive amount of data, taking into account these multidimensional variables. Okay, so using that, I'll just share a little bit about what is out there. Nothing groundbreaking that I invented or whatever, but it's more of what's in the literature that we should know about for sepsis phenotyping. So we divide it into two kinds of subclassing. One is phenotyping, referring to observable characteristics, and endotyping, which takes it one step further by looking at the disease mechanism. Okay, so we are referring to genotype, certain biomarkers, and what we call omics, all kinds of omics. Okay, so I'll present a few papers for you all to get a flavor of the exciting things happening out there, and very soon, I think will be happening in EDs regionally and maybe even locally. Okay, so this paper by Christopher Seymour and colleagues is, I would say, is the seminal, one of the most important papers on the topic. Okay, so he and his colleagues combined multiple data sets from randomized controlled trials. Okay, and what they did was they took commonly available variables, meaning variables that are available even to you or I during our ED visit. Okay, blood tests, vital signs, comorbids, that kind of things. Okay, and he used unsupervised machine learning, okay, and generated 4 groups of patients. Okay, and of course, because of the kind of variables he put in, there were some explanation by organ dysfunction. They tended to be divided by organ dysfunction. But when he repeated, he did a simulation of the RCT, right? I mentioned use RCT data set. There was a difference in the outcomes of the RCTs, suggesting that if the RCTs had recruited based on phenotypes, that might have very well changed the outcome of the RCT. The second thing he did was to look at the biomarker expression. He noted that these 4 distinct groups also express the biomarkers differently. And these are, not the conventional, white blood cell, CRP, PCD. We're talking about certain IL-10, ICAM, and so on. Okay, so just a diagram so that it's not all words on my slides. Okay, the phenotypes came up to four groups, and the biomarkers shown on the diagram on the right show a differential expression, especially IL-10, IL-6, PAI-1. Okay, another gentleman, I think, Bhavani and his colleagues, did a different kind of phenotyping. Okay, they actually looked at temperature and vital sign trajectories. And once again, they combined data from some randomized trials. Okay, and once again, interestingly, they found 4 subphenotypes. not explained by the usual, SIRS or SOFA score or, Apache score. So it's not a severity phenotype, but really a distinct vital sign trajectory phenotype. And when they reran the randomized trial based on phenotype, it changed the response to the trial they used was one that compared balanced crystalloids versus saline. Okay, so do these exist? I mean, until people do prospective studies using these phenotypes to recruit, we can't say for sure, but I do think there is a hint. Now we talk about the other side of the coin, right? Looking at endotype, meaning the disease mechanism. Okay, so this is my favorite actually. So this group, Demerle et al., they actually combine both clinical data as well as biomarkers. Okay, and the biomarkers being these three, IL-6, PAI-1, and ICAM, and they found two phenotypes, right? Which is to me the most convenient for us ED doctors, because it's like you do this or you don't do this, right? Rather than 4 phenotypes, and then you got to do 4 different things. But they found that this latent class analysis of this data found hyper and hypo-inflammatory phenotypes, correct? With oligo-directed therapy actually making things worse in one of the phenotypes. Okay? And the last one is Wong and colleagues. Okay, these guys did something pretty ambitious, I would say. So they collected pediatric patients and they did a genome-wide study. So they actually found 100 relevant genes that, after running through the machine learning, was classified into 3 subgroups. Okay. Notably, one of the subgroups actually do worse when you give hydrocort, right? So we give hydrocort whenever we put patients on vasopressors. But that is a clinical signal, right? We don't actually know whether the patient that we are giving hydrocort to is having a hyper or hypo-inflammatory response. Or some would believe that the hyper and hypo-inflammatory responses are simply along a time course. One comes after the other, and we need to know at which point in the disease state the patient is in, so we can decide whether to give hydrocort or not. Okay, but anyway, so this team subsequently showed, okay, this is the most challenging part, right? They actually repeated the genotyping on the patients several times, okay? And they found that when they repeat the genotype testing at day 3, 42% of the patients has changed endotype, okay? And their responsiveness or outcomes as affected by hydrocort was also changed as well. Okay, so this further supports really that for sepsis, one of the big issues is about determining time zero, and that there might be different treatments at different points in time. Okay, and this is really up the alley of us ED doctors, right? Because time sensitive, which phase is the patient in, we got to decide the right treatment for the patient. Okay, so that is an overview of phenotyping and subclassing in sepsis. So the challenges that I foresee really is that, number one, when we talk about phenotyping, I think from a clinician point of view, at this point, we are still largely thinking, we are still largely human reliant, right? So we want to make decisions based on like, okay, do I give or do I not give? And I think most of us would be very happy if they came out with a universal phenotype that we can decide treatment based on. But my suspicion is that the pathophysiology of sepsis is a bit too complicated, and we might end up with many different phenotyping techniques that will predict treatment response to many different treatments. Okay, and that will present us with a different group of challenges, making implementation of clinical phenotypes in sepsis very challenging without a good EHR system or good clinical decision support system, alongside regulatory systems that allow continuous training and improvement of such algorithms. Okay. The second part is timing. Okay, so many of these phenotyping techniques take time, okay, especially if we are doing genome sequencing and whatever not. So the development of new POCTs to detect the phenotype will always be several steps behind the discovery of the phenotypes. So unless we're able to, come to a consensus or very good evidence that certain phenotypes do exist and are very clinically relevant, it is unlikely that commercial entities will start to develop timing tests to determine the phenotypes so soon. So from that point of view, we're talking about many years delay before we see the fruition of such efforts. Okay, the second part about timing is that, certain interventions must be immediate, right? So we're talking about 1 hour, 3 hour interventions. So until the day we have POCTs, it will be impossible to bring this to clinical practice since our lab turnaround times and all that are simply not fast enough. Okay, the last part is more a systemic problem when it comes to phenotyping, which is about R&D, right? Because sepsis is a difficult population to recruit. Okay, as alluded to just now, even the current studies from 5 years ago are already, recruiting sepsis 2 definition of sepsis, which is already different from what people today are recruiting for sepsis 3 definition. So I don't know whether we are still going to play this game of sepsis 4, sepsis 5, or, are we going to stick with sepsis 3 for a long time to actually facilitate a very consistent inclusion criteria to develop and innovate around this topic. The second part, of course, is that recruiting patients on septic is obviously a little bit difficult in certain countries, depending on the ethical stance of the IRBs, whether or not we can, take samples when the patients are a bit delirious, they are a bit confused, or are we going to exclude all unwell patients and only recruit well patients, which also doesn't make sense from an R&D point of view. So those are the challenges I foresee when it comes to sepsis phenotyping. And that's it. I think that's all I have to share. I will be very excited to hear any questions on email or later on in our discussion.
Thanks, Zhen-Hong. Just can I ask all participants if you have any questions, please either put up your hand or let me see whether I can actually get this up. Yeah, or type in the chat, because then we can actually easily see the chat and bring up the questions for everybody. Okay. While I wait for questions from the floor, can I maybe just satisfy my own curiosity from I understand that is Prof Chan still around, or he has already gone to sleep?
I think he has go to sleep.
Yes. Right. Because I still see his icon. Okay.
It's all right. I can answer some questions. Because he is one of the best experts in Taiwan.
Yes. Okay. Maybe I'll just ask Dr. Song, because we haven't started using the DPCR. So I assume, listening to your lecture, that the DPCR is actually not affected by antibiotic use. Is that correct?
Thank you for your question. In my opinion, DPCR can cause because it cannot distinguish the bacteria whether it's alive or dead. So it may cause a false positive result. But so the result of DPCR, I think it should be affected by antibiotic use, because in my presentation, there are several research to observe and monitoring sorry.
Yeah, no worries.
Yeah.
Because
Yeah. So
so it will be affected by antibiotic use. Means that
I think
the patient actually has been on antibiotics for the last 3 days, for example, before they present to the emergency department. Does it decrease the chance of your DPCR getting a result?
yeah, antibiotics can decrease the result.
I see.
I can see from our results.
Right. So it is just like the blood culture also affected by antibiotic use.
Yes.
Ah, okay. The other thing I was going to ask is that I realized that you put down there as BSI infection, but because
BSI
it's
infection.
PCR, is it able to identify things like virus or fungus? I mean,
Yeah.
because Zhen Hong has just said that, frankly speaking, infections and
it
sepsis
can.
has not
It
been.
can detect.
So it does also identify both virus and fungus for the DPCR.
Yes.
Okay, and the last question I have was the particular case that you have put up. It was interesting because each time they stop the antibiotics,
Yes.
the value goes back up. And then if they stop antibiotics, the value goes back up again. So is there do you think, this is just an opinion because I know we haven't done it yet, do you think that DPCR can be used to determine the length of antibiotic use? That means when do you stop using antibiotics?
We are going to do some investigation to find out if DBCR can determine the length of antibiotic use. But I think the length is very complicated. It can, due to the patient's different condition. The case I mentioned is acute jaundice. Yeah, I'm sorry.
Yes, acute cholecystitis.
Yes. So maybe we should. I don't know whether the patient received any procedures to drainage the resource.
Right. Whether there's any surgical intervention.
So maybe the patient is a little complicated. We cannot use the results of the only patient to affect our opinion.
Yeah. But your team is actually looking into research to see whether you can actually use DPCR to determine the length of antibiotics use or when to stop treatment.
Yeah. We are doing some. We are working on it.
Sounds great.
Thank you.
Thank you.
Thank you.
Is there anyone with any questions? I can't really see the whole. Any other hands on the board?
Yeah, may I ask a questions about the phenotyping?
Great.
Yeah. Dr. Liu's presentation is quite interesting. I would like to know, are you doing phenotyping during your daily practice in Singapore, or just only research? Because we never do such kind of phenotyping in Taiwan, so it sounds very interesting. This is the first question. And then the second question is that if you are doing phenotyping, according to your experience, have you changed your way of treating septic patients according to the result of the phenotyping? Thank you.
So I'll give a short answer and a slightly long answer. The short answer is I don't think anyone in the world is using phenotyping as a pinnacle decision. That's one. The second thing is that phenotyping is still a broad term. So if I want to be playful, all of us are doing some phenotyping when we put an ultrasound probe to determine fluid responsiveness. When we touch a patient and we say this is cold or warm shock, that is one kind of phenotyping. But it's all clustered in our clinical gestalt in our head. I'm not sure if there's anything in mind, but anyway. So we are doing, so the question now is, I guess the question is, the eventual state of phenotyping, will it be based on pathophysiology, meaning we'll figure out that there's different types of sepsis, different disease, or will it be a functional phenotyping, meaning we figure out characteristics that tell us straight away, do not give hydrocort, don't have to give certain kinds of antibiotics, or give certain renal or hepatoprotective medications, or give certain immuno medications or fluids even. So I wonder whether we will end up with that kind of functional phenotyping that has no relation to underlying pathophysiology, or we'll end up with a very nice, this is sepsis type A, do this. And we expect sepsis type A to end up in cardiac complications, for example. So I think that's where the excitement comes in.
Okay, thanks, Dr. Liu.
Thanks, Chen Hong. I am just sharing, okay? So it is interesting when I actually listen to your talk, because I have a slight interest in TCM. And the interesting thing about TCM is that they look at the person's response to illness. That is almost their basis of TCM. That's why each person actually has, and they call it in a way, a type of phenotyping. Okay, because that's why some people say I very zua all the time, or I very liang or whatever. I have a tendency to have epistaxis if I take heaty stuff, and so on and so forth. So I am just wondering, as you say, if you want something really, really concrete, you may take really eons and years because we're starting from scratch. Whether, since you are in research, that you will consider perhaps combining with TCM, especially now Singapore is starting to support TCM, to see whether the TCM phenotyping types can help in making the diagnosis. Because if you can, then you have actually almost half the battle won. Because, you already have that whole thing behind you, and to use that to do as a basis for your research to see how is their response according to the TCM phenotyping might be a faster way of doing if it works. Just a comments kind of stuff.
That is very interesting because we have thousands of years of experience in the Asian tradition. But we oftentimes look to the Western literature to get ideas, which is always a bit odd. And even some of the things that Prof. Chen's lecture was speaking about, they use a remote RPPG to determine, is it vasodilated or vasoconstricted? Could that be just a representation of a digital pharma kind of thing? It does spark my curiosity, and I'll definitely think quite hard about it.
Yeah. Sorry, just for fun kind of thing, because that was what strikes me as you were going through, the different phenotypes done by people on their response to illnesses. I think that was also part of the reasons why a lot of the illness whereby we define as one disease, for the TCM side, they defined it differently. They think that it is different diseases. Yeah. Okay. No, but that was just for fun. Okay. Can I just ask, is there any other questions? Anyone?
Yeah, I know that that's an expert from from the Taipei, from the National Taiwan University Hospital or VGH, they are doing some genotype study for the sepsis patients, and they conclude that the genotype may determine the prognosis of the septic patient. But I think the cost of the genotype are quite expensive and not applicable in most of the EDs in Taiwan. But it may be the maybe we may do further study in the future. That's all what I know. Thank you.
Thank you. Okay, may I ask Julian to conclude our session?
Yeah, I'm very glad to have all our colleagues from not only Singapore, Taiwan, and also from Beijing, Tsinghua. I think it's quite great to see more experts to join us. For example, Prof. Chen is one of the leading experts of sepsis in Taiwan. And we also have some young colleagues from China and also from Singapore. I would like to invite all the colleagues, not only limited to the doctors, but also nurses and students, medical students who are interested in our webinar, and we will keep on doing the webinar in the future. Thanks again for joining us. Thank you. Thank you.
Thank you, everyone. Bye.
Bye.
Thank you. Bye-bye.
Bye. Thank you.
Bye.
Bye-bye.
Only you just send an email.